Well, good morning, everyone. My name is Mary Viktorovich. I'm the interim director of the Ottawa Institute for Global Health Research. And today I'm delighted to welcome you all to the 7th annual Critical Social Science Perspective in Global Health Research workshop. This event is an opportunity for researchers and faculty to gather, generate new insights, and discover new research opportunities in global health research and critical social science perspectives. Before we get started, I'd like to offer a land acknowledgement. First Nations people have lived in this part of the Turtle Island for millennia, stewarding the land, the water, and all that contribute to the life of this region. Today, the culture and presence of First Nations, Inuit, and Métis people enrich the lands and peoples of this territory. More than 2 centuries ago, the Mississaugas people welcomed settlers to this territory, providing sustenance and engaging in trade and commerce. Between 1781 and 1820, 8 treaties were signed between the Crown and the Mississaugas of the Credit First Nation. Territory to development. Today, York University's Keele campus is located on Farm Purpose Treaty number 13, and it's situated on the traditional territory of the Huron-Wendat and Haudenosaunee. Treaty history is foundational, and it's our collective responsibility to honor the land as we honor and respect those who have gone before us, those who are here and those who have yet to come. We're grateful for the opportunity to be learning, working, and thriving on this land, and we commit to learning truth and be active in the process of reconciliation. So today's event is part of the key program here at the Ottawa Institute. The Critical Perspectives in Global Health program showcases a strong commitment to critical problem-solving approach in global health research. By employing social science theory and methodology and engaging directly global public health actors, structures, and systems, this program aims to achieve greater equity, effectiveness, and excellence. Today's program is comprised of 2 components. The first is a workshop for academics to collaborate and further discuss critical global health research, and we'll be hearing about ongoing research projects and new proposals. The second is our seed grant program, which we'll discuss in more depth further into the workshop. So with that, I'd like to pass it over to Professor Maggie McDonald, who will be taking us through the next steps. Oh, and just before I begin, I would also like to thank everyone who's helped. So Natalie Patterson and our colleagues on the CPGH committee, of which Maggie chairs.
Thank you. Well, thank you all for being here. It's actually really wonderful to see familiar faces. I'm the chair of the CPGH committee, Maggie McDonald. I'm a professor in the Department of Anthropology, and I'm a medical anthropologist by training, which is what brings me to the Ottawa Institute for Global Health Research. So as Dr. Viktorovich was saying, this is our flagship event for the Critical Perspectives in Global Health Research stream within the DI. And I am going to moderate, keep everybody on track, do some introductions. So I'll just let you know how the day is going to unfold. We're going to start today's agenda with our keynote speaker, whom I'll introduce in a moment. And then we're going to have two presentations from our seed grant recipients last year, and I'll introduce them when the time comes. The annual seed grant program is one of the centerpieces of the CPGH committee, and its mission is to support faculty members and interdisciplinary teams embarking on research concerned with global health that uses a critical social science framework and methods. After that, we're going to have a short break at some point as well. And then after that, our third kind of segment is what we call pitch presenters. It's faculty members and students from across York who work in the area of global health and critical perspectives who will be sharing their ideas for future research. And this segment serves in some ways as a kind of dry run for the seed grant applications that take place in the spring. Again, as Mary was saying, there'll be more on that towards the end of the workshop. At each segment, there'll be time for Q&A, and I'll monitor the proceedings throughout and try to keep the whole thing on track. So thank you very much for coming, and we'll get started. So it's my pleasure, I think there's a slide there. It is my pleasure to introduce our keynote speaker for this event, Dr. Andrew Pinto, who is the founding and current director of the Upstream Lab, a research team focused on tackling social determinants of health, population health management, and using data science to enable learning health systems. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He's a public health and preventative medicine specialist and family physician at St. Michael's Hospital of Unity Health Toronto and an associate professor at the University of Toronto. He is, it's a very lengthy list of, so I'll continue. I'll just continue and be thorough about this because you're quite accomplished and quite busy, obviously. So Dr. Pinto is the director of the University of Toronto's practice-based research network, UpLearn, the lead for clinical research of Ontario's Poplar Network, and founder of the Canadian Primary Care, yes, very busy. And among other roles, he serves on the Institute's advisory board of CIHR's Institute of Population Health. He's an active scientist at the Institute for Work and Health and an honorary executive lecturer at the University of St. Andrews Innsbruck. So we're very delighted that Dr. Pinto accepted our invitation to travel up to York this morning and to share this talk entitled Global Health and Ethical Actions, Connecting Our Work to Movements for Social Justice.
I should first apologize for the lengthy bio, because I also, you'll hear kind of throughout this work that I think such a key aspect of what it is that we bring to this is an aspect of humility. And that didn't sound very humble, but that's, you know, a more a reflection of all the privilege that I have that I bring to this work. We started with land acknowledgement and of course where I'm working in Toronto and where the Upstream Lab is based is also in the same jurisdiction covered by the same Treaty 13 and on the same traditional lands as here. But when I just note that I always want to say that we have a particular kind of need to remember the calls on truth and reconciliation commission. And the really important aspect of thinking about within the health sector, there are specific calls. So I always urge you, if you haven't, to look at this specific calls that are related to health institutions and health researchers. And also I'd like to provide something tangible. This is a really fantastic paper by colleague Eve Tuck, who's now at the University of Toronto. And just a really useful paper to help us actually think about this is not moving, actually we were talking before we started, moving from theory into actual practice as well. I'm going to move through this fairly briskly, and also, you know, please let me know if you can't hear me at the back. I'll try to project. This is our team at the Upstream Lab. We're now about 10 years old, and it's a home for a number of scientists. I'm just one of a number. We have a fantastic group of people, staff and graduate students who work together. And we like to divide our work into three main areas. The first being, how do we build upstream health systems? And these are two initiatives, something called the Deep End, GPs in the Deep End for Canada, how building a network of primary care providers working in the most deprived areas, prepared a national initiative around preparing for the next pandemic. A second area of work is around AI and data science, and how do we use these new tools in a way that is just and equitable. So these are two initiatives around building a national task force around primary care EMR data, and also I'll come back to this, building a public movement called Our Health Data. And the third area of work is around trials. So this is an international adaptive platform trial called TreatRest, working with colleagues in different countries, really trying to quickly evaluate and efficiently evaluate treatments for infections, including whatever the next pathogen is that emerges. And also we're the home for the Canadian Primary Care Trials Network. So the lab has kind of this, we're based in Toronto, but have a lot of collaborations and work across the country and beyond. So I was thinking a lot about this day and this work that you do, and really argue that this work in bringing a critical social science based approach to this work is actually the most important aspect of global health. It really is the overall kind of thing that is steering this massive ship of global health. So I would encourage all of you, regardless of kind of what stage of your training or journey you are, around first thinking about these questions and try and think about them by the end of the day. How do I understand how the world works? And how has that been changed by what I heard today from colleagues who are pitching new ideas? What are your values? And also, what does this mean for how you should act, but also how collectively we should act? And how do I connect our collective work in global health to movements for social justice? And we'll walk through it. So I'm going to start by thinking at a high level about global health, talk a bit about some of the work that I've done with colleagues around global health ethics, and then move to kind of the connection to social movements. We, of course, live in a very deeply unequal world. This is just one of many examples, and I won't spend a lot of time going through numerous examples of this, but this is where child mortality is concentrated, maternal mortality, and where it's concentrated. We see this starkly in life expectancy. We can see these are the top 5 countries and the bottom 5 countries, massive gap in life expectancy, of course. What we don't sometimes see is also the internal kind of changes. This is, stark data from the US, and it's been also found in the UK and Canada as well. But the drop that we're seeing in life expectancy, almost all of which is concentrated in people who are living in the lowest income groups and the most marginalized. And so this is, of course, the social determination of health. This is where we are seeing all of our health is shaped in large part by the conditions in which we are born, work, grow up in age. And what's so key to this definition is that it's linked to how money, power, and resources are distributed. And that's I think an important question when we think about this. How is the work that we're doing, often in academic centers and spaces, is it contributing to a redistribution of power, resources, or is it sometimes actually worsening that and concentrating power and resources? We have a very good understanding of how social determinants get under our skin. And I want to emphasize this is not an abstract issue. This affects all of us, from the neighborhoods we live in, our exposure to things like air pollution, the type of work and how stressful it is. But all of us are affected. Of course, in our society, some of us are very privileged and protected, and others are not. With this afternoon, I'll be in clinic at St. Mike's. And many of my patients are at the very, very lowest bottom of this, and they truly experience this. And they are the ones who are dying at incredibly early rates in their 50s and 60s. And I see that on a daily basis. And part of this is also, of course, how we've constructed societies. This is, just a series of examples here in Canada of what we see. This is the average cost of a house versus median income, and the amount that has departed, even with the recent kind of a bit of a correction. We see this in kind of the low rates of social assistance that our society provides, which really means people who are living with a disability are living on a pittance, really, truly, barely surviving in our incredibly wealthy society. We see these really horrible stories of people, and unfortunately, this is becoming more and more common, people choosing MAID or euthanasia to actually end their life because they are actually struggling so much. And we saw this starkly during the pandemic. We did this rapid review. I think when the pandemic was emerging in early 2020, many community voices, many folks knew this is going to hit certain communities much harder than others. There was, and we all saw this. We saw that there were those of us who were able to work from home, shelter, kind of continue, were able to be employed. And then there was many people who lost their jobs, couldn't afford to pay their rent, or had to go to work and were exposed. we did this rapid review of the evidence in the first 3 to 6 months of the pandemic and showed that it was lower income racialized groups who were really dying and getting infected with COVID. So we knew this. With a lot of pressure, communities called on government to track data on the social determinants of COVID. And it's very rare in Canada that we do this, but government initially, public health was initially quite reluctant, and then they kind of bowed to that pressure, and it showed these kinds of stark examples. Incredibly high rates, made far disproportionate to their population in terms of the Black community, South Asian community, and many other groups. And you can see this kind of racial disparity. I mean, thankfully, it wasn't all a negative, because this created a foundation communities to say we need ambassadors, we need outreach programs, and actually the vaccine rollout in those first couple of years reduced these inequities that we saw. In terms of COVID, thinking outside of Canada, we also saw this. We went through this pandemic, and I think for me, this is something that the global health community has to grapple with. We went through this pandemic. There was a lot of really good ideas beforehand about distribution of resources, of support to one another in a pandemic context. And then what do we see in terms of vaccine doses? Like, the vaccines were not reaching the most at risk, the most vulnerable countries. Canada, very shamefully, really opposed efforts to liberalize and open up intellectual property and actually support vaccine access to others. There's been some progress and I think some reckoning around the kind of pandemic treaty that exists, but we have a long ways to go. And so we know this, that unequal societies are unhealthy. And this is, work from Wilkinson and Pickett, and a lot of work that you're probably familiar with. This very strong relationship between unequal societies and these index of different things, from everything from life expectancy to homicides to many other things. So we know, we can predict as we never can before, and there's no shortage of data of what we are going to confront in this century in terms of health and climate crisis and things like that. So we have a huge amount of knowledge. The question is, and this is particularly important for those of us who are academics, is to not just continue to describe and describe and describe, but how do we move into intervention? What is it that's going to ignite in us kind of a movement to moving towards action? So global health, this is one definition. Area of study, research practice puts a priority on improving health and achieving equity. It emphasizes transnational issues, determinants, solutions involving many disciplines, well beyond kind of traditional health sciences, and is really this idea of population-based prevention and individual clinical care. This is a fair definition, but what's missing from this? And hopefully that first part of the presentation got you thinking too. We're missing often an explicit discussion of power, of relationships, an acknowledgement that we're all embedded in often reinforcing systems that actually maintain this inequity. And often we don't talk about ideology. We're actually I would say in many Western universities, we're very scared of talking about and naming kind of the ideologies that shape our work, and being, very aware of that. This is just, two different ideas, WHO kind of classic definition of health, and then the People's Health Movement. How many of you have heard of the People's Health Movement? See, about half of people. So really powerful, more grassroots-led movement, well worth, kind of checking out their work. And their chapter, there's actually a chapter in Canada as well. But the idea that health is fundamentally a social, economic, and political issue and a human right, and kind of drawing that. And who is to blame? Who is actually causing this illness? It relates to inequality, poverty, exploitation, violence, and injustice. We're on the brink as a global community with the war in Iran that was begun by the US and Israel. And it's going to cause massive, massive disruptions in things like fertilizer and access to food and things like that and fuel. And we're already starting to see this in many different countries. What is the cause? If we're just describing the problem, like famine started, children died, women died in childbirth, didn't get enough nutrition, and we don't name the cause, we're not doing our job. We're not saying this is linked to this violence that was created by these people. So one, kind of an approach is thinking about global health as more of a contested term. It's used actually mostly by anybody who has worked in, quote, global health in other countries notes that if you look at it, many of the centers of global health, many of the institutions, many of the people writing about global health are based often in academic spaces, or they're practitioners or donors, but communities themselves often don't use this term. It describes activities that trace back to tropical medicine and international health. And Emmanuel Byrne, a colleague, has done really great work on tracing the history of the ideology and thinking behind global health. It has these goals of reducing health inequities, improving health of everyone, and does reflect roots in public health and human rights. Interventions span a wide range of things, but the interventions are influenced by the social, political, and economic philosophies of those who fund and direct them. And global health is very relevant to discussion of work with marginalized communities in high-income countries. So part of our task is to break down this, high-income country, middle-income country divide, and really recognize that actually there's enormous kind of integration of those two. I would say, moving kind of to what is the role of ethics then in this? It's actually helping us move from an intuition that probably all of you have already, kind of a gut feeling, into a deeper understanding of power, how people access resources, justice, and fairness. And what we are doing with ethics is we're trying to interrogate different levels and understand how they're linked in order to, one, avoid harm. We want to try to avoid being complicit in the harm of others. We want to more effectively do our work and reduce inequities. And ultimately, it has this effect of changing our own thinking. So hopefully today, one of the things is actually you are open to and your thoughts actually change on this topic. So let me turn to a very Canadian example, and probably many of you have seen some of the analysis. So Me to We, which is a movement and an organization that's now been around for a while. To me, this is a very Canadian example of how the public often thinks about global health work. And I'll say right at this stand, I feel this is an incredibly problematic organization and way of doing things. It described itself as an innovative social enterprise that offers socially conscious, environmentally friendly products and life-changing experiences. It uses images like this. And I want you to think about what I said about power, resources, distribution of that, and this image, right? And who is the recipient, who is the victim, and who is the giver, and who has that. Also, these types of things, and I was checking their website today, they're still very active despite some of the scandals that I'll talk about. But they are saying very explicitly the solution is to consume, is to buy stuff. And they are selling. And even this type of thing, like, is your spirit indestructible and buy this tank top, right? So what is the ideology that is underpinning this? Why is it also so successful? Like, that's the other thing. If they really were bad as an organization and they didn't succeed, they didn't raise millions of dollars, they didn't, have thousands of people go on these types of trips. They didn't have the former prime minister speak at their massive rallies. They are a very, very successful organization. But think about it. What is it that is part of us? Like, this is not just, oh, look at these people over there. Look at this organization making money and victimizing people and it's us. It's all of us, right? There's something about the Canadian public which this resonated with, that this was like a key turning in a lock. So a lot has been written about, then the subsequent scandals of this organization where it invested money into real estate in Toronto and so on, and what are they doing? There's a fantastic podcast which I think really unpacks this that I encourage you to listen to, that maybe sheds light into this one. So coming back to ethics, so keep that example, one of the most successful kind of Canadian initiatives involving literally tens of thousands of often students, inducting them into this way of thinking. So think about global health ethics. How does this help us to understand how to evaluate different courses of action at the individual and collective level and what their consequences are? And what our challenge is often to draw the connections between all of these different pieces. What is the impact of you as an individual academic, an individual student, an individual health professional, and then the impact on collective and community action as well. And it can be very difficult. The goal is to introduce a critical mechanism of analysis, consider how power, resources, motivation, affect, and how this then leads to harm or benefit. It unpacks the scenario to understand kind of the latent issues, to consider history, and provokes us to consider our values. Often, global health is a different area of work. It often deals with different situations. There's often much greater power differences that are reinforced by historic processes. There are cultural differences, and there's a much greater weight of the social determinants of health and structural violence. And I'll note, when I talk about global health, I, would define it as thinking about the health of marginalized populations that have been made marginal by policy, social and economic policies, whether they're in another country or in Canada. So we essentially, Ross Upshur, who's a prof at U of T and previous lead of the Joint Center for Bioethics, he and I wrote this paper actually while I was a student, and it got taken up and then publisher invited us to write a book. We didn't feel we had all of the knowledge to do this. We invited a large group of colleagues to provide different chapters on it, and this is kind of the output of that. Both in the paper and in the book, we walk through 4 principles that I would say we try to bring to this work. The first is really beginning with humility. And I'll say that we propose 4. There's obviously, you could choose any number, but many of you who've taken kind of a classic bioethics class know that in traditional clinical bioethics, we often think about 4 principles like beneficence, non-maleficence, autonomy, and justice. And so we replicated that with these kind of 4. But beginning first with humility, what is our limits? Whether it's you're in a clinical context or you're in a research context, challenging, medical tourism, questioning what is one's place in the world, especially where we live in a world where some lives are valued much more than others. Questioning, are we reinforcing a kind of a neo-colonial approach? And this is particularly important in any kind of academic work because it really can magnify a lot of the disparities. Secondly, kind of thinking about introspection. What are our motives, when it comes to this? Really being honest about that. Is the expense of what we're doing, the funding, whether it's for research travel or clinical, travel, is it justified? Where are we coming from in terms of our privilege, whether it's class, ethnicity, gender, or education? Are we integrating an anti-discriminatory analysis to our work? What will be the actual impact? And is this actually addressing the no-do gap? So very tough questions, I think, for any academic or any practitioner. And sometimes it leads to a recognition that this is not the right course of action. I shouldn't do this. Or I'm not the best person to do this. Third, solidarity. How are we, it's a word that, we don't, again, we feel hesitant to use. It has this kind of connection to socialism and communism. And so in the West here, we have this particular prejudice against this. But I think it's a really powerful value. And actually, in the last kind of 10 years, we've seen a lot more writing about solidarity and work by a number of scholars around this. But that are our goals aligned with people who we're serving in the community? Do we have conflicting visions of health needs? And if we do, how do we essentially reconcile it so that community needs are put at the forefront? I think we see this a lot actually with the ongoing experience of Indigenous communities when it comes to their health and what their priorities are versus what, say, the federal government's priorities are. Can we bridge power imbalances? Can we specifically tackle economic, political, and social challenges? Can we envision kind of a global commons, really recognizing that it's just by a nature of history and privilege of where we all are and how these systems have been set up. And Solomon Benatar, who's a prophet in South Africa and often has worked and come to Toronto, talks a lot about this idea of moral imagination, the ability to imagine ourselves in the shoes of others to change our outlook and our actions. And then finally, social justice. How is our work actually working towards diminishing inequality and addressing structural violence? Really being able to answer that question, is this work that I'm doing going to help with the distribution of power, money, and people? And of course, thinking, as Paul Farmer talked about, as being historically deep and geographically broad. So it's a tall order to think through these 4 principles and to apply it, but I would say it's well worth it, and it results in a much richer experience, and you're aiming to avoid doing harm. One of the ideas, again, from Anne Emanuel Byrne is to take a political economy approach to this that considers political, social, economic contexts in which they arise, and really interrogating the social structures, how they interact. And this is not new thinking. Engels famously wrote a very long time ago about his observations of the working class in England, and he called it social murder, what he saw, what was happening to workers. And this is a more contemporary example. This is from 2021, an interview with a nurse who's in New Orleans during the pandemic, kind of at the heart of it, saying and naming and saying, like, I'm working as a nurse, but I'd say what it is that it's capitalism is the reason why I'm crying, why I'm feeling overwhelmed by debt, and why I recognize that I have to still go to work, even though I could get sick, my family could get sick. You understand what it means when people say you're a cog in the machine, and where if I have to protect my family, but I still have to show up for work. So capitalism means I don't get a choice. I don't get to decide. And so again, communities, workers, people who are impacted, they understand, they recognize, and they often know of the solutions to the problems as well. What we're challenged to do is to really simultaneously think about things at multiple levels. It really is hard, and it's a difficult cognitive task. And it's actually quite hard, I think, in research where we're focused on one small part of a bigger picture. But again, I think actually this field of critical social sciences is actually the most important and has the greatest tools to synthesize this. I'll try to illustrate this with an example. So I've had the privilege of working as a clinician in different settings as well. And so just picture yourself in a context like this. You're working in a clinical scenario in a low income country, and you see that there's a 5-year-old girl who has pneumonia. The immediate kind of thought is the solution is to provide an antibiotic. But what is unpack, and that may be the right choice. That's an obvious thing. So the kid has pneumonia, antibiotic. But what else is surrounding this? And that's the challenge. So what is the care culturally appropriate? Is there consent? just, is there translation so that the family understands what's happening? Is there any follow-up? This is a massive problem that the, antibiotics or medications are dispersed, there's no follow-up. What if she develops an allergic reaction? What led to her getting pneumonia? Is there access to vaccines that prevent it? What if she's living with HIV? And then what are the broader social factors that led to this young girl getting pneumonia? How does it relate to also where clinics are located? Why did she have to go to an NGO clinic? Are there fees at the government funded clinic, or is there basically nobody at that center, so they have to come to the NGO? What could have prevented her becoming HIV positive? And what are the broader kind of higher level things at a national and international level that really shape this, what seems like a very simple kind of thing? I know many of you understand this right away. A lot of workers in global health who are often clinicians, I don't think are trained, and it's not their fault necessarily. They're trained to just focus on the pneumonia equals antibiotic. They're not always trained to think about this much bigger picture, particularly these much further upstream aspects of what are the role of donors and philanthropists in shaping this and actually impacting on TRIPS or legislation that controls intellectual property. How did this come to be, and also what's the solution? So lots of things, and I bet if we spend half an hour, we could add even more to this picture as well. This is just an initial. So just to conclude, how do we then go from this kind of critical view of global health, understanding kind of the need to pose questions, to think from an ethical perspective, maybe transform our thinking, and then unpack scenarios like this? How can this work linked to movements for social change? So let me begin by talking about what is a social movement. I think we all have a certain sense of it, but it could be defined as a distinct social process where actors are engaged in collective action. It's characterized by conflictual relations that are with a clearly defined opponent. It could be government. It could be a corporation, it could be an employer, and so on. That there's linkages with dense informal networks. That's often how movements kind of begin. And there's a shared collective identity. Whether this is a social movement of, say, women in Iran, or it's a movement of Uber drivers in a city like Toronto, or it's a movement of, and I'll talk about personal support workers in Ontario, or things like that. There's something that brings them together. How do they get started? Often in reaction to a social policy or a demand for new rights or benefits. And often there's something that triggers this. There's maybe a change in a condition, change in beliefs and values, a change in the capacity to act collectively. So we've seen this a lot with new technology, like WhatsApp or others that allow people to organize and connect with one another quickly. And there's often a policy window that opens that allows this kind of movement to happen. They emerge from this kind of intersection of that personal experience that worker community member has, and the collective and the historic moment that they're in. They're impacted by social norms and attitudes. As an example, I see in our local city here, there's a growing movement around tenants and tenant rights. And many of you have probably seen kind of news coverage of tenant unions forming. Some of you may belong to one. And I think we're seeing an opening where we're recognizing housing is just so inaccessible, and there's so much of an uneven scale that it's starting to stimulate these types of movements. They never emerge fully formed. There's many groups that federate, there's ups and downs and challenges, but there's a reliance on kind of core ideas, and often leaders play a key role. And really they're composed of regular people who become activated and become politicized. Why I'm talking about this is because social movements, I would argue, are absolutely essential to the policy change that probably all of us want to see. They are the mechanism. All of you who are in academic spaces know well that it's not going to be publishing a paper that is going to lead to policy transformation. I wish it was, as we all publish lots of papers and that would be wonderful, but it's almost never the case that you publish a paper or write something and then boom, there's a change. So policy movement is a very challenging space, which often requires social media. What does it mean, I would say, is moving us into the space of being an ally. We, of course, have meaning-based participatory action research as a very well-developed model for this work of how we can really build relationships in them. Academics and professionals often have access to funding, grants, conferences, and training opportunities that are really important resources. We know that building these relationships takes time and resources itself, which is why SSHRC, CIHR, and other funders do fund partnership development grants, and I'd really encourage you to look at those as really useful opportunities to actually get the resources to build these relationships. And research can be used in turn to support these, solicit questions and priorities, assemble the evidence, and importantly, evaluate and hold government accountable around policy change. I don't have an example of this, but I don't have it in the slides, but just an example from our own work. Some of you may remember during the pandemic, government in Ontario and a few other provinces actually put a ban on eviction enforcement. Pandemic happens, people are told to shelter at home. There's a lot of pressure from on government to protect people. But one of the things they do is actually say, we're going to put a ban on enforcing evictions. It's interesting they didn't say it's a ban on evictions, but just the enforcement. We did research using interrupted time series analysis, and we used freedom of information to request to get the data. And what we showed is that during the pandemic, that eviction filings did drop in the first part, but then quickly kind of went back up and actually exceeded kind of the initial kind of approach. So using research to actually check and say, what did the policy work and did it result in what we expected? I'll give you 3 examples from the work that we've done. The first is the Decent Work and Health Network. So these are all, I'll mention all Canadian examples. So work here. So the first was colleagues at the Workers Action Centre, which is a nonprofit based in Toronto. They recognized that there was a great policy window when the provincial government was looking at the legislation around labor and employment. And they encouraged health providers to look at this and to bring their voices into it. And so we started an entity called the Decent Work and Health Network, which was mobilizing health workers in Ontario to actually talk objectively about the evidence between work conditions and health outcomes. And so we organized groups, and many of the ideas actually ended up in the review, and some of it actually ended up in the legislation. Another example that kind of built from that was around looking at personal support workers, or PSWs. So actually, by doing this work of building an advocacy network, the Decent Work and Health Network, we recognized that we were often talking about other workers in agriculture, gig workers, workers in factories. But then the question came up, what about the health sector itself? We recognize that within the health sector, there is these huge differences. You have physicians like me, and then you have staff who are cleaning, who are security officers, often contracted out, and then you have personal support workers. So it led us to specifically focus on personal support workers, and talking with many of them, we recognized that actually nobody had looked at their work conditions. So we received funding from a foundation to do research using something called respondent-driven sampling, which is a very useful technique to be able to reach a hard-to-reach group. And we, not surprisingly, found horrible work conditions, often patterned on race and gender as well. And that led then to the PSWs building their own network, the Empower PSW Network. to actually advocate for their work. So kind of looking at how research advocacy can lead to research, can lead to advocacy. And interestingly, kind of bringing it back to thinking about global health, colleagues in Peru who were really interested in looking at the work conditions of female domestic workers in Peru, they saw that we had used this method, respondent-driven sampling, and they said, let's use that. We want you to train us in this method, and we want to use it. And so my colleague, Archana Gupta, who's another scientist at the Upstream Lab, co-led this work with colleagues in Peru. We received an IDRC grant, and essentially we applied this method to these domestic workers in Peru, and they've used the evidence to advocate for work conditions, for finally getting some basic rights preserved for these. Vast majority are women, vast majority come from Indigenous backgrounds who are working as domestic workers. And then a final example that's just started is actually engaging Canadians in a discussion about health data, kind of building off of work we've done around the problems with AI and kind of where we're all going with this space. Lots of concerns about what companies are doing with our health data. And so there was really no movement of just Canadians, what do we all collectively want with our health data? So this has just gotten started really since over the last kind of 4 to 6 months. So there are many other examples that you could identify of powerful social movements that have been linked to academics and researchers that have led to change, whether it's access to antiretroviral therapy in South Africa, NSF's work on looking at lead poisoning in children who are working at gold mines in Nigeria, refugee health cuts, and kind of the work here in Canada. One of that last example is maybe a good kind of example to drive home the point that the work doesn't end, unfortunately. So there was cuts that were proposed to refugee healthcare about 10 years ago. The massive kind of outcry and movement led to them actually the government pulling back. Now again, the government just in the last couple of months is again saying we're going to cut funding for refugee healthcare. So again, there's a need to move. And this really can make a difference. This is some work from the World Health Organization, the relationship between policies that support families and things like child poverty or things like infant mortality rate. It really can lead to lives saved and change happen. So just to conclude, maybe a final kind of way to think about this, because I know it is tough to think through all of these things, but thinking about history, how did we get here with this situation? What are the resources and how are they distributed and why is that? Power, who is making decisions in this context? What are the values that we all decide should guide our actions? And also resistance. What can be done to change the situation? What is our individual role and what's the collective role? So I think that truly understanding what we mean by global health is really crucial. It's a beginning point. A global health ethics lens could be helpful. I've suggested some ideas for our own values around humility, introspection, solidarity, and social justice. And I think that the collective level we can add to that and another kind of approach. And of course, a lot more work is required. So I'll stop there and happy to take questions.
Well, thank you so much for that really interesting talk. We've got about 15 minutes for questions, a little bit more. So I can help look for hands, or you can.
I can just
Okay.
And I'll say that I think all of us as adult learners, we learn best when we are engaging in a discussion. So I hope there are lots of questions. Yeah, please go ahead.
Can I just introduce yourself really briefly, say your name, at least say your name, maybe in your program or.
Hi, my name is Yulia Churna. I'm PhD candidate in social anthropology. Maggie is my supervisor. Thank you so much, Dr. Pinto, for your presentation. I'm really, really impressed, and it resonates very deeply with me. My dissertation research is about tuberculosis, and it's also a disease of inequity. So your frameworks that you shared really gave me some inspiration how to look at my data and my analysis. And I wanted to ask you, in your presentations, you mentioned about the social determinants. I know this kind of a framework also quite well, I think. But I also noticed that you, in your speech, you mentioned social determining.
Mhm.
Was it for purpose in ways like causal relations, or was it like just a figure of speech? And also, if you would now suggest any revisions to the social determinants framework, because I think it's from early 2000s, what could it be?
Yeah, I'll just flip back to that. It's a great question. So we can all see this kind of useful framework that was created. Here we go. Okay.
Yeah.
So yes, so first on it was a conscious kind of decision to say social determination. I do think there's a lot that's been written about the language that we use, and different groups saying we should move away from social determinants, social determination, and a very variety of different ways of saying it. I did say that because I do like to I think one of the problems with how we train, particularly health professionals, but also many others, undergrads or graduate students, we often talk about social determinants in a very static way. We actually have a paper where we criticize this kind of thing, and we talk about it like a laundry list, that we often tell students the social determinants are income, gender, race, housing, and so on. And it actually is problematic because it doesn't communicate the fact that it is a dynamic process. I think sometimes people come away thinking, well, that's my lot in life. Like that's just how it is. And actually we know this is an incredibly dynamic kind of thing where it is actually a social determination of health that's happening. For example, I think we all see this, that when people are continually struggling for just basic needs, if they have much less capacity to organize and to actually advocate for policy change that's going to be at a higher level. Or if there is kind of an overall cultural view that some people's like knowledge or views are not valued. We can think about the history in Canada of colonization, where Indigenous language, ways of thinking, practices were made illegal and really almost driven to extinction. That influenced the policies that were happening, and also those communities' ability to mount a defense and response. Amazingly, many have survived and through that process, but you can see it's a dynamic kind of, I think, link to this. To your second question, do I think this needs to be updated? Yeah, I do. And the WHO has had a process over years of trying to work towards updating it. I do think it's still very useful in general. So I think as much as we can refine these, I think there's a lot of value to this type of conceptual model. Your own work on TB is a really interesting example of this, pathogen that we've known about for a very long time, have excellent treatment for, and also have excellent ways to reduce spread and looking at living conditions. And yet, Canada still, and many high-income countries still has TB, which is something that should, shock and disappoint many Canadians. But yeah, it's a very good, I think, example of and the ability to apply this type of model. Yeah, over here and then over here and then yeah, go ahead.
Thank you so much, Dr. Pinto. My name is Naima. I am a PhD, global health PhD student. My research focuses on equitable global health research partnerships with a specific focus on like institutions, like funders, journals, and universities. But my question really is about the great work that your lab has been doing on the Income Security Health Promotion Project.
Mhm.
And maybe if you can talk about that and like how that pilot has really demonstrated the importance of, you know, the relationship between social determinants of health and why that's important when we approach like patient care and sort of, yeah, just like I'm very aware of the project, but I just wanted to make sure that
Yeah.
everybody else knew like how great it is.
Oh, thanks. Yeah, happy to talk about that. So this was really a very much from the experience of many clinicians who are working in countries where you have these deep inequities and you have insufficient social systems. So what happened was at the St. Mike's Family Health Team, which is quite a large family health team with now over 80 physicians serving about 50,000 patients, of whom about 30% are living in poverty. There was a recognition that when we are seeing patients, we could spend a huge amount of time treating people's diabetes, treating their hypertension, trying to, help with cancer screening and dealing with acute issues. But at the root cause is often poverty. And so what could we do around this? So we're able to get funding from the Ministry of Health for a health promoter, and then a second person. And what they do is they actually specifically focus on income security. So they work with our patients around kind of three areas. How do they reduce expenses that they have? How do they increase income, often through applying for government benefits, helping with tax filing, things like that? And how do they also increase financial literacy? There are still, I will always say it's not a silver bullet, and there are challenges, like not everybody benefits from the program. Sometimes things are very, very complicated. The health promoters have limited time, like everyone in the health setting. But interestingly, we did a randomized controlled trial of this with a waitlist control where everyone got the intervention, but some people got it more rapidly than others. And we found that there's some positive effects of this. So it's I think like one part of it. There's a whole separate, I think, area of work, and actually on our labs page, you can see a lot of this kind of how do we integrate social interventions into existing health systems, and also what are the limits of that? Because I often think that's like the tip of the iceberg kind of work within. Ultimately, you need to go to that policy change, but there can be a connection between these pieces, because as you integrate social interventions into traditional health systems, it actually inspires people. It gets them activated to be engaged in more policy kind of work as well. Yeah, go.
Hi, thank you very much for your presentation. I really like how you brought up a bunch of things that would, in theory, like not directly contribute to the research, but clearly it's the research is built off of. And I like the fact that you're a practitioner as well, and that's what my question is about. Because my name is Brian, and I'm a Canadian American. I did my master's in America, and now I'm here because one of the things I found in my master's degree was I could bring up things like participatory research, and then I'd be asked, that's fine, but like, how does it contribute to your research? Like your outcomes. And I bring up things like building up relationships, and they say, that's great, but how does that improve your survey? And it was always kind of odd how everything had to be, there was only one value at the very end that we could target. And the reason I came to Canada is I felt that there was a lot more opportunity to engage in the SLO scholarship, engage in more, like bring more ontologies and more ways of seeing, and more values in the research rather than just the output. And one of the things I've been really interested over the last couple of years is that truly like a Canadian-American divide that you've seen? If you're talking about this kind of just in this presentation, I'm sure it's not the first. Have you seen this in a Canadian-American divide, or is it an institutional divide? Because also we're at York, which is one of the most like progressive universities, I think. So I'm kind of curious. I have a limited exposure to, I have a limited sample size. I think yours is a little bit larger. Is this a Canadian-American? Is it an institutional thing?
Yeah.
What do you think?
It's a great question. I would say that, and I've had the privilege of working with a number of American colleagues. There's actually a really great network called the Social Intervention Research and Evaluation Network, based at UCSF, or SIREN. And they have done a great job compiling a lot of the evidence on more upstream interventions and kind of social intervention research. It's a primarily American network. I'm actually the only non-American at this kind of group, but it's helped me see a bit of what they work on. I would say that actually there's lots of great examples in the US of people doing this type of work and working with kind of centers in Boston, LA, kind of San Francisco, New York. There's like a number of different kind of centers that have done this. I think it's not necessarily a Canadian American kind of divide. I think maybe because you're at York in a more specific institution, is you have that kind of sense more, but not all Canadian institutions are like York here. So in fact, I had that my own experience with that. I did my undergrad and master and was really mentored by a number of physicians who really were engaged in this work. And then I came to U of T for medical school, and it was a culture shock. Like I literally had people complaining to the dean about me, like about raising issues in a medical school, like and saying this is not medicine. So that it was a good experience in a sense of challenging me to explain what are the social determinants and why we should be talking about these things in a medical school. But I do think institutions, is probably bigger than the kind of national difference. I think that's kind of maybe a really key point, is to foster that within institutions. And how do you build a culture of critical thought in institutions? It's a really important part of the work that we all do. It's tough because there's also a discordance with sometimes the corporate goals of the university, and so that can be hard to navigate. I mentioned just briefly kind of the role that donors play in shaping work, and that's another reality. And so navigating that within institutions can be hard too. But it's something that all of us, I think, are charged with, is how do we continually bring kind of a critical lens to the work we're doing and be able to ask tough questions and say, you know what, was the community really involved with this? Was this a priority? Who is kind of speaking about this? Yes, at back. And yeah.
Go ahead, Peter. Okay. Your tasks from the School of Health Policy and Management. Thank you for such a very interesting presentation, and I will pick you up on the theme of a deeply unequal world. And you spoke about equality and inequality, and power and resources. And I just wanted to ask the question around those constructs and the relationship among them. And resource dependence theory by Pfeiffer talks about those that control the resources have the power, and thus the inequity that we are experiencing in our world. What can we do in a realistic sense to relinquish, or for those that have the power, to relinquish the power and distribute the resources more equitably, whether it is for health or whether it is among social determinants of health, based on the work that you have done? What are some realistic strategies that, aside from activism, that we can pursue in moving towards that development?
Yeah, it's a good question. I just touched on it briefly about what is our role as academics in tackling this distribution of money, power, and resources. So it's interesting because my own journey to get involved with research was, I actually never thought I'd be a clinician scientist or be an academic, but it was kind of as I was going through my public health training that I realized that research had this huge potential. And the research that we do at the lab is very, very applied research. It's really often very pragmatic in a community or in a hospital or things like that. But I think there are many things, actually, if we pause to consider, that we can do. And just thinking about that kind of money, power, and resources, On the money side, there is enormous kind of potential for us to share actual money that we get through grants, through funding, through donations, and actually see this distributed to communities. It is something that's tough because I think a lot of us come into this work from a kind of we've striven and there's a lot of rejection in academic work, papers get rejected, grants don't get funded, and so on. And you're always kind of feeling embattled. And then to kind of approach this with more of instead of a deficit approach, a more that we have a lot of resources is hard. It takes like a mind change. But I think actually redistributing money is part of it. I'll give you a very concrete example. Last week we found out we were awarded one of the CIHR partnership grants. And it builds off of work we're doing on kind of pandemic preparedness work. And it's actually a project that we developed with organizations that serve migrant farm workers in southern Ontario. Many who come from other countries, work here for periods and so on. They are very vulnerable in a lot of different ways, but they also have organized and have a lot of power. Yeah, as we were writing this grant, we were really talking with the groups and the clinics that serve them. And they specifically said, like, we really want some of these resources to come to us. And I thought that's very fair. Absolutely. Like, the point of this is to help with your work and for you to direct this partnership and where we're going to go. So we built within the grant funding for their workers, their staff and so on. So I think money is one piece. Power is something we all can work on, that we can all seed power. The nature of our institutions is that it concentrates power. And unfortunately, we use these terms like principal investigator, the head of the lab, the director, and so on. We rise in ranks. We have a very hierarchical system. So it is you are actually trying to go against that process, but you can seed power. We can seed it in who is on steering committees of projects, who are kind of authors on papers, whose voice is heard. Speaking to kind of a previous comment about how do you measure the impact of that, you can quantify it. There's very good approaches to actually measure how many times people speak in meetings and who is speaking. And also, we do this thing in some of our projects where we actually trace back, was it a community member or patient, partner, or person with lived experience who raised an idea, and how often do we actually action that? So if someone says, for example, I think the wording of this is way too complicated and I think we should change that. When we look back in the minutes, did we actually do that? So you can do that as part of auditing. And then resources, I think often there are many different types of resources. There are physical, tangible resources that we can actually see redistributed. And there are also resources like who gets to host an event, who gets a PhD scholarship, and so on. So there's different pieces. So I think actually in our work as academics, we convene people, we actually provide funding, we train, and we answer questions. And there's a lot of that we in our own work can do it. And I actually would say challenge us to not see this division between objective academic work and activism. I don't think that they're actually that separate. The tricky thing is to say, even in our own day-to-day lives, how are we activists in potentially negative ways too? How do we, in the way where we put our money and what we choose to do, the people we choose to connect with, how are we actually advancing maybe a less healthy options as well? Thank you.
Thank you, Andrew, for that really fascinating talk and very thought-provoking as well. I have a comment and a question. So the comment is, thank you for raising some of the issues around the reorganization. Because earlier I had done some research on and found that when they go into the communities, sometimes they displace local workers and put them out of work. When I tried to look at their financial accountability because they're a charitable organization, it wasn't available. So there were a number of sort of warning signs that beware of this organization. So I think for all of us to do our research before we engage in those kinds of organizations. And the second, the question I had was just before your talk, we were talking about UHN funding housing for some of the homeless. And you were a little bit, I guess, critical maybe of that model. And I'm wondering if you could elaborate on that a little bit, because it's actually quite interesting.
Yeah, I don't want to single out any specific, or because I think actually what we need is many organizations trying different things and experimenting and then really evaluating them rigorously. I think it's this kind of comes back to the question about integrating social interventions into existing systems. And you could take any public organization. This could be a university, it could be a health system, it could be social housing. There are many different publicly funded systems. How do we actually integrate this type of work? And I think some of the questions we have to ask is like, what is the amount of resources that are being put, and is this the best kind of approach? What will be potentially the return on that over time? I think we have to ask, like, also, are we potentially the best people to deliver and I think like this income security health promotion service that I talked about, you could very justifiably say, is our health promoters in a health team the experts, like in things like financial benefits, or is it something that they could be trained in? And it turns out you can do training and and get that support. I think we have to ask, like, the scale too that this is going to help with, and how much energy we put towards individual interventions versus more policy change. So as an example, like if you had, say you were getting a $10 million donation, and it's specifically to tackle housing, that money could be used in many different ways. It could be used for direct individual service delivery. It would probably help a small number of people over a period of time. Could that create an engine that also helps with policy change? Could that be something that is thinking about how do we see this actually tackle some of the more policy challenges that are leading to this downstream effect? One example is, for example, rent control. When rent control was essentially removed from a lot of housing that was built, I think after 2018, what is that doing in terms of creating more precarity, more precarious housing, and then that's going to lead to a lot more people who need it? What would it look like to involve some of our work contributing to that kind of reversing that policy to try to go upstream of it? It's a complicated thing, and this way of thinking, I think, takes time and a lot of discussions. And coming back to an earlier point, often the communities that are affected are the ones who have a lot of the solutions. It doesn't often actually predominantly come from academic centers, but it comes from us working and listening and collaborating and then and working together towards it. But I really feel we do have a role to play, both in kind of a positive way through convening, stimulating discussions, rigorously evaluating things, but it can also be a negative way where we reinforce to the me to we kind of example, something that reinforced it was our own school systems. Our schools, our school boards, our public school boards really got entrenched in this whole apparatus because they thought it was good, they thought it's educational or something. But there's ways that we, unfortunately, all of us, myself included, we can reinforce systems, or we can be working kind of to try to redistribute.
One more question,
Yeah.
or maybe two quick ones.
Wonderful presentation. So I think we also heard from Professor Ross Upshur last year in 2024 in one of our sessions with the DA seminar, Clinical Public Health, and people know that. So there is a book, and global health ethics, and we had a great chat with him. Of course, my question is related to the global health ethics. When we implement research or kind of do some practice in global health, so we can ensure that all the core ethical principles or the revised principles which you have mentioned, the solidarity, social justice, introspection, and the humility can be implemented. But while you were developing these principles, how did you address to minimize the foreign gaze, especially linking with these principles? Because a lot of time, even we had one seminar last year, all the global health research or the ethics related frameworks were developed in the lands of high income countries, or the global north. So how these frameworks, or even including these principles, are kind of eliminated from the impact of the foreign gaze. So what kind of mechanism or strategies you used to kind of remove this foreign gaze?
Yeah, and so it's the issue is that like these principles were really developed in high income country settings by academics like Ross and myself. And then how do we actually see it extend into and engage colleagues in low and middle income countries? Yeah, it's a great question. And I think it's a very fair critique, like who are we to propose these kinds of principles? I think the initial impulse, and I actually did it while I was a medical student with Ross as my supervisor. I think it was a first year medical student, which is really, really a long time ago now. And but the impulse was actually to turn the mirror on ourselves, and say, we have all been doing this work without a lot of actual critical thinking about what we're doing. It was actually directed predominantly to students and practitioners who were coming from mostly high-income countries and mostly going to low-income countries. In our subsequent work in the book, we had really that same thought you had, and we then engaged a far broader set of colleagues from low and middle income countries. There's a chapter on the book actually on a view of global health from the global south, which was really quite interesting to see what is the perspective of colleagues in these other institutions who often are forming partnerships or collaborating. What does that look like? And kind of really, it sounds like your PhD work is on what makes those partnerships work or what makes them not work as well. There's some really good work that's been done by the Canadian Coalition for Global Health Research around this, a really thoughtful kind of approach to partnerships, partnership building, and kind of assessing them as well. That example I gave of colleagues in Peru who saw our work and said, we want to use this method. And what made that project work really well is they were in control the whole time. It was really their needs, their kind of ideas, their questions, and the majority of the resources from that IDRC grant were theirs. Because it was an IDRC grant, they needed a Canadian PIs, and they needed that, so we facilitated that. But it was a very strong kind of example of partnership, and it's continued, which has been quite useful. A great question. I think you had one last one. Yeah, go ahead.
Thank you for that presentation, Dr. Cook. My name is Kushi. I am from the MA Digital Media program, and I work at the SATS lab. My question was regarding, you mentioned how academic research affects policy. I'm curious to know what that process kind of may look like, and whether that entails engaging lawmakers and policymakers at any stages of research.
Yeah, absolutely. It's I think we sometimes also think policymakers are like this other type of person or something. There are people like us, many who have gone through academic halls, and there's they are faced with the same challenges that we are. In fact, that's maybe part of it. Is the first is really understanding what is their day-to-day, why research does or doesn't get kind of integrated. We sometimes, I think, all can see the end result, but we're not really aware of how they got to that point and why, and what are the things that are buffeting them. So policy, engaging with policymakers is crucial to this work. Ideally, not alone, but with community members, like where you are acting as a bridge. Like I know that I can reach out and have a meeting with, say, Jane Philippot, who is a colleague and someone who you may have known. She actually authored some of the work in the book, and she's now leading this primary care task force. So I have this relationship, and we could connect. But what I should be doing is bringing community members into that meeting and making sure she's hearing them. So you act as a bit of a conduit to what their kind of thoughts are in terms of, in this case, like access to primary care and things like that. But yeah, I think relationships are really key. I think understanding what are the problems policymakers are faced with today, and really seeing you as a resource to them. And then over time, it leads to the work you're doing, shaping the policy, but the policy questions also shaping your work and this kind of back and forth.
That is a great question to end on. So Dr. Pinto, thank you very much for your presentation. We have a coffee break immediately following now. So if you can stay and mingle a little bit, that would be great. And if you've got more questions for Dr. Pinto, maybe you can just, approach and engage in a bit of conversation. But join me in thanking Dr. Pinto for Natalie, is it there or is it out of the vault? It's there. Okay, so we're running late, but we've got time. So we're going to take a 13-minute coffee break and reconvene at 10:45. Okay. All right. Thank you all for coming back to your seats. I know that it was difficult to stop that conversation after the presentation. But we do want to move on without getting too far behind in our schedule. And so before we start the presentations for this segment, I want to just briefly remind everybody of this seed grant program that we have, which is, as I was saying, kind of one of the cornerstones of the critical perspectives on global health research. And this year, so every year, we've been doing this for about 7 years, Mary, do you think?
Yeah.
And it changes a little bit. The number of grants we are able to give changes a little bit from year to year. This coming year, we'll be offering 4 seed grants, valued at each up to $8,000 to initiate novel and innovative ideas that take a critical social science approach to global health research within our 3 themes: global health and humanitarianism, global health foresighting, and planetary health. So we part of the purpose of the program is to stimulate global health research and encourage full development of grant proposals by one of the Tri-Council agencies. So we strongly encourage applications from faculty members, but also postdoctoral fellows, with the support of your faculty member as a principal investigator. And principal investigators are entirely free to hire their graduate students to help carry out that research if they win the award. The application deadline this year is 2 weeks from today, Thursday, May 24th. And we have a pretty quick turnaround on that decision making. So, but this segment now, we want to hear from our 2 CPGH seed grant recipients from last year. So I'm going to introduce them. We have, we're going to start with Fauzia Gibson Fall. Dr. Fauzia Gibson Fall is a research fellow at the Dada Lang Institute, and her current research looks at the role of security actors in global health. And today she will be giving a presentation. I think it might be up, shall I forward? Let's find out. There we go. The title of her presentation is Actors in Global Health, Setting an Agenda for Research. So thanks, Fauzia. We're going to have the 2 presentations in order, and then we'll have time for questions afterwards.
Thank you so much, Maggie. Hi, everyone. So lovely to be here and see you. Last time I was here was last year. So it's really nice to have this sort of full circle moment with you all. So I'm really pleased to be speaking to you. It will be a bit of repetition for those of you who were there last year, because you do have to get you up to speed on what this was about. So bear with me. I remember as a student, I was always so annoyed with researchers who were just presenting the same slide over and over. But I'll have to, the first couple of slides you might have seen last year. So my name is Claudia Gibson-Flo. I have my email address at the end of this presentation if you want to get in touch, if you're interested in this research area, you want to exchange on some of these questions. So I just wanted to give you a bit of an overview of where my research is at the moment and what was the kind of foundational thinking around the seed grant in my application. So my research is very much now comprised into a book that is admittedly being submitted to Johns Hopkins University Press. It's called Health Warriors, the Global Politics of Military Health in Africa. And it really looks at the historical variation of military involvement in healthcare systems and governance, the African continent. So I take a very historical approach. I look at the lives. I'm a political scientist. I'm very much interested in sort of the international relations aspects and the critical theory aspects of these questions. And I look at the role of the military in the everyday and in health systems. And this is very much a critique of the way in which we've understood military actors in global health. And I think we've understood them very much as emergency actors, when actually there's a very sort of day-to-day role of these actors that we haven't really managed to tackle because we've been so obsessed with sort of securitization and militarization as a gradual emergency process. And so I looked at the role of military in international relations in Africa as part of diplomacy in Africa. And I really sort of formulate a critique as part of the book and as part of my upcoming articles around the disconnect between the way in which we've understood the role of militaries in global health and the way in which they're actually active in the everyday, especially in low and middle income countries. And that some of the tensions, the political tensions that are arising on the ground are often not included in the way we thought about it in global policy and in global advocacy. So this was my background research, and I wanted to expand on this. And so this project last year, I came and I pitched this project, which was a kind of threefold or three-step project. One was to go to Senegal. I did my PhD and most of my data collection. It was during COVID, and I hadn't managed to be there in the flesh in person. And I thought that online methods were actually pretty brilliant to uncover some of those more difficult conversations with people. I found it very productive to not be there and be on WhatsApp often with people, and surprisingly helpful. But then I was very keen to go back and look at some of the archives that I hadn't seen in Senegal, and this grant has allowed me to book that trip. And those of you who travel to West Africa often will be pleased to know that there's a new Air Transat flight between Montreal and Dakar. Very cheap. Highly recommend if any of you do research in West Africa. I was thrilled to be able to book that flight for the end of August. So I'm going for a week at the end of August. I was hoping to have gone before I talked to you today. And actually this has whipped me into action. But unfortunately, because of childcare and responsibilities, I had to delay the trip till August. But I'm very thrilled. Tickets are booked. Thanks for the seed grant. And then I'll be giving a workshop at the Pasteur Institute during that week. I've been liaising with the director of the Pasteur Institute, who used to be at WHO Emergencies and is now the head of the Pasteur Institute in Dakar. And I will be presenting some of the findings of the book and getting feedback on that in August. And then the kind of crux, the really center of this grant for me was to really think about research expansion and how to set the agenda for security actors in global health research, and how can we think about it and sort of convene colleagues and build a community of concern. I'll speak a little bit around that and how that went. And I in my introduction slide, I mentioned I'm also an affiliate here, of course, at the DI, but also at King's College London, where I've done most of my career for the last 10 years. And so I held a workshop there in London as well. So highly recommend, anyone who's sort of toying with ideas to apply to this grant, just because it's such a luxury in this economy to be able to speak to colleagues about your research project and get feedback and get people thinking and sort of think about funding. And so I've really appreciated both the workshops I've held in London and here in Toronto, and I'll speak to both of these. And the idea behind that research extension was really to try to make sense. And I think if any of you are interested in security dynamics, you know that the last year has been just, you know, in your personal lives and in everyday and current affairs, just an incredible turn of events. And on the front of global militarization, definitely this is a picture I took from an article that came out last week on Al Jazeera, and it's a really interesting little, very small newspaper article, but it's basically a journalist at Al Jazeera compared the data from the Stockholm International Peace Research Institute, which sort of tracks global militarization and military funding. And I mean, you can go and see the paper, but basically what it's doing, what the graph is about, I should have put the whole graph there, but I thought the image was impactful, but the graph looks at military spending and sort of compares it to education and health expenditure in various countries that CIPRI, Stockholm International Peace Research Institute, have quantified. And so it's a really interesting moment and probably terrifying moment in many ways in terms of military expenditure and the way in which countries have really shifted and started militarizing more and more. And if you're Canadian, which I'm sure the majority of you are, you know that we are now receiving the global, I'm not sure what the name of the new bank is, but we're receiving a new military global development bank in Canada. And I think these conversations, and as scholars, we need to start thinking about what does military expenditure mean for our research and our programs. And so in this context, I wanted to think with colleagues about the role, what these sort of global dynamics and tensions meant for the role of security actors in global health. So big program, interesting and very large conversations have happened in both these settings, and I'll get back to them. But really, I wanted to take this opportunity to reflect upon sort of very, very unfolding dynamics. I know that Rachel will be speaking to sort of the funding cuts at USAID, for instance, in her specific areas of interest. But in my own research, I've really spent the last couple of weeks as I finished up the book and trying to make it as relevant and topical as possible. And as I was preparing for these workshops and reflecting upon them, to think about, for instance, Trump's new MOU. So if you're not familiar with US foreign policy, so the new Trump administration has sort of rebranded a new and repurposed a new global health agenda for the America First global health strategy, and to look at MOUs, and a lot of them are quite secretive, not disclosed, but to look at specific African MOUs. The MOUs have been signed by 21 African countries by now. By this week, I think we were still at 21 last time I checked, and just look at the MOUs and what they meant in terms of security actors in health. And if you have any questions on it, please do and ask in the question time. Also, I just wanted to signpost the context of sort of thinking that the UN is doing around peacekeeping and the redefinition of peacekeeping mandates, and what that meant in terms of sort of healthcare involvement as part of mission. And so I convened colleagues, around 10 colleagues. I kept it very small. I didn't want to go over the 10 people mark just because I wanted to have actionable conversations in both these workshops. But I convened colleagues who've had a very wide variety of research and research portfolios, mostly scholars, so I didn't go fully into policy actors. Some people have two hats and have worked, for instance, at WHO, and will have some affiliations within both universities. But people who sat down with me for both these workshops were, for instance, people who worked in One Health, so veterinary medicine, One Health approaches, epidemiology. We had some people from Canadian Uptake Policy. We have some people more interested in IHL and peacekeeping. We had people working in AI new technologies and health equity, governance, climate adaptation, international human rights law, and water and sanitation. So it's a very sort of large bucket of colleagues. Not always like-minded, and that's what I wanted. I wanted to create a bit of polemic and reflection. And really what I wanted us to do and what we have done so far, and there will be another workshop in Dakar on this, but I wanted to think about people's experiences of military and security actors involvement, so in their own research. So for instance, working in water and sanitation, how does that look in their field? I have no idea. I don't work in WASH, but people will have specific experiences of what that looks like for them. What might be some country-specific noteworthy civil military health delivery. So a lot of my work has been to look at African military health systems and the way in which they provide healthcare in communities. And I know that is happening in many places, like Pakistan or Jordan, for instance, were key examples that I'm not necessarily familiar with, but that has been really interesting. And also the way in which, and I wanted people to think not only, a direct security involvement, but also at the most sort of like military logics and the more sort of intangible
ways in which ministries can be active in research and governance structures. And I wanted to set an agenda, and for them to set an agenda. It was very interesting to hear different perspectives and also different methodologies. And so, this question of positionality, of how do we engage, who should engage, which organization should be thinking about this. So the WHO, for instance, just published, and at my workshop in London, and I can speak to this a little bit more in a minute, but my workshop in London, these workshops were held under Chatham House rules. So we, not recorded anonymity, but some of the colleagues present were saying, we've actually done some data collection around civil military interaction with healthcare systems across the world. Many case studies, it's still under publication. It's still under review, but it was so interesting to see that work was happening that I was not necessarily aware of. And so we also thought, and that was a really important question, so we also thought about funding and ways to fund this research agenda. I kind of identified some good calls that I think would be relevant to putting this agenda forward. We thought about sort of how do you, so MIND, for instance, if you're not familiar with defense funding, MIND is sort of new Canadian defense fund that is being used across, social science departments. And so what are the sort of cooptation and implications of that type of funding for this type of research? It was very interesting to get the ethical perspective of colleagues, and that's part of my own research as well. And there we go. I know I am running out of time, so I just wanted to give you a bit of context. So the two first workshops happened, one at Bush House in London on the Strand, one here, and then the next one will be happening at Pasteur. And I'm really looking forward to closing out each conversation and to reflect on their takeaways. There we go.
So as I said, we'll have some questions. You have a little bit of time for questions later, but the next presenter I'd like to invite is Dr. Rachel Silver. She's an assistant professor of education and faculty affiliated with the graduate programs in anthropology and development studies at York University. She will introduce the research. The clicker is there.
The clicker is here.
All right. Hi, everyone. It's nice to see you, and thanks for the introduction. Maggie, I won't reintroduce myself then, but it's very nice to see you all. And I just want to say that I'm going to do a couple of things today. I want to offer a bit of a progress report on the CPGH Seed Grant funded pilot study that I've done. And I want to give you a bit of a preview of some of those findings and then talk about where we're going from here. So my sincere gratitude for this funding opportunity and to the adjudication committee. It was very helpful. Before I get started, I want to acknowledge that this project has many partners. You can see on here colleagues in the US and in Malawi and here in Toronto who have taken part and will take part in varying aspects of this work. Okay, so just to set the stage a little bit, this is not going to be new for most of you. We all know that President Trump in early 2025 froze and then gutted USAID. Slashing more than $50 billion of aid spending. And by July 2025, he had shuttered USAID completely. So the speed and scale of these cuts sent shockwaves around the world and destabilized the global order in which the US had wielded tremendous financial and symbolic power, excuse me, through its foreign aid. So as we all watch, significant media attention, such as the examples here, has been paid to the devastating ramifications of USAID's closure, especially for global public health and food security. Yet millions of people also risk losing access to schooling. So in my work, I'm an anthropologist situated in the Faculty of Education, and I look at the intersection of education and health, for instance, around sexuality, health, education, et cetera. So I can talk more about that later, but this is how thinking about schooling in relation to the other ramifications of the aid. Okay, I want to note briefly before we go on that while USAID is unique in its scope and speed of the closure, the aid austerity is a much more broad global phenomenon. I put some numbers up here, but the UK made a major cut in 2020 during the COVID years and again in 2025. Germany, Canada, and France are all cutting aid respectively, as you can see the numbers up here, which means in total, global aid spending decreased by a third in 2025 alone. So this has transformed the organizational landscape of international development and radically reconfigured possibilities for well-being worldwide. Okay, so actually prior to the USAID cuts in December 2024, together with the Malawi and US-based research team, I set out to think about the implications of aid austerity from those who work within the industry. So specifically at the mid-level, sort of the civil servants, NGO workers, clinicians, teachers, who make up international development, education, and health in their everyday work. So we had sought out kind of prior to Trump's moves to think about how different organizations, in one context, Malawi, which I'll talk about in a minute, how folks working in the sector were starting to imagine ways forward in light of aid austerity. And then, of course, as we all know, the USAID closure happened. So we set out with three main research questions. The first, how do people working in international development from diverse geopolitical and institutional locations understand the effect of these cuts? Second, how do they imagine the future of international development broadly and in Malawi's education and health sector specifically? And finally, and I think the third question is the most interesting to me, what other possibilities for partnership and funding futures do folks working in the sector imagine or enact? So just to give you a sense of where we are in the study, and I do want to note before I go on that the entire project is framed from a critical political economy approach. So throughout, we're kind of beginning with the understanding that aid is not an inherent good, that aid, in addition to positively impacting people's lives, also replicates very harmful dynamics. So that's kind of where we're coming from. So how these shifts can both rupture the status quo and potentially generate new possibilities. So I mentioned that we did a pilot study prior to the cuts, or we went to plan the project in December in Malawi 2024, did some initial interviews right as USAID closed. I applied for and received the seed grant in the middle there, which helped fund a graduate student here in Malawi to do a second round of pilot interviews last summer. We applied for external funding to the Spencer Foundation for a 3-year longitudinal study of this stuff in that summer as well, and then wrote and published a piece in ARA Open, which is the American Educational Research Association journal, with a colleague of the University of Toronto, looking at the immediate impact at both the level of global organizations and Malawian educational organizations. So we're here now. We just received, we were very fortunate to receive a Spencer Foundation grant. I'm giving this presentation, and then next week I fly to Malawi, thanks also to the seed grant, to do two things. We're launching a case study with one NGO partner, and then we are also going to sit down with the Malawi-based team and plan this broader project together. And so that is sort of the next 3 years. So I wanted to give you a sense of where I am. So because today is kind of dual purpose, I'm trying to give you a little bit of a sense of our findings and also a sense of this bigger project. I'm going to race through some of what we wrote about in this piece in ARA Open. So just to give a little bit of context, it was co-authored with 2 people. It's based on these 62 initial interviews that were done in Malawi and with folks in global aid organizations. That's the piece that Francine Menashe at the University of Toronto did. And so both of us had, both Alyssa and myself and Francine had larger ongoing projects looking at aid austerity. And so we came together to address the research questions 1 and 2 that I mentioned, which is more kind of what are the initial impacts of this and how are they being understood from folks within the sector in multiple spaces. And the idea was to kind of set us up for this what comes next bit. I want to give a really brief, for those of you who were here last year, you also heard this already, but I want to give you a quick answer to the question of why Malawi as a case study and what is unique about thinking about power relations in international development in Malawi specifically. So briefly, I've had the opportunity to conduct research in Malawi for over 15 years and have partnerships with folks in several universities and NGOs. And given the high concentration of aid interventions for the population in Malawi, and given the percent of the government budget that is subsidized by foreign aid, Malawi offers a really unique space to think about power relations in aid. However, it's equally important to note that Malawi also has a very rich tradition of critical political economic thought and activism in both education and health that kind of helps scaffold thinking about possibilities outside of the neo-colonial relations of aid. And so here are a couple of metrics, mainstream metrics up here that kind of show what it means to think about aid in Malawi. 70% of the population living at or under the poverty line. 1.34 billion in net aid in 2022. That's an old statistic, but takes a few years to catch up with what they report. And that represents over 50% of total government expenditures. So that's what I want to point to. And USAID in particular was equivalent in spending to more than 13% of the country's budget. But I do also want to note that all of this has to be made sense of in this sort of critical frame that I mentioned. And these metrics are very limited in their ability to tell the story of a place and its history. So I want to kind of situate these metrics critically. But that's why Malawi in terms of thinking about power relations and aid. So I'm a smidge limited in time. So I'm just going to give you a couple of brief tidbits from this article about sort of what happened when Trump shuttered aid. And so development workers across our interviews, from the global policy arena to local NGOs in Malawi, described the event and the week after as marked by chaos and confusion. So as the cascade of directives came from Washington, the freeze, stop work order, and project closures, folks tried to make sense of and interpret their impacts on their lives and livelihoods and on the so-called beneficiaries of programming. So what was unique in both cases is they distinguished this round of cuts from past austerity measures. And frames them within broader national narratives, from calls to government ownership within Malawi to the anti-progressive movement in the US. And so you get a brief sense of what this looks like from folks about talking about horror of things being cut off and the horrendous nature of it, how rapid it's been, how shocking. In Malawi, some of the metaphors that came out in conversation included an airplane that when it's taking off, it happens at an angle. And when it's descending, likewise at an angle. And the aid cuts felt like a 90-degree descent, a plane crash, that it was so quick in how it happened. And someone else said it was a planet shaker because it's unprecedented. People never expected it. We are far, far away from the US. It was a shocker. So our findings, which are provided in much greater detail in the paper, point not to the shock of the aid cuts, but to the nature of them. And I go on, and I'm actually going to skip through this because I imagine we're running down on time. We talk about the ripple effects of the aid cuts in terms of jobs in both the US and Malawi, in terms of US global relations. So I'll flip through this now because what I want to focus on for my last couple of minutes actually is about future imagining. So I'm going to skip forward a bit. So as participants reflected on what they imagined would come next, their responses conveyed contradictions. Some felt only despair, whereas others identified optimism in the moment. Some sketched idealistic alternatives and others demanded pragmatism. These contradictions characterize responses across the global and Malawian interview sample. Yet the project of imagining new futures was propelled by an ability to place USAID in the past. Despite the tragic consequences wrought by the rapid cuts, many respondents spoke candidly about how the move addressed a long-standing need to curtail US influence on the global stage. For many Malawians specifically, the shift opened conversations about how aid itself was, quote, not right. Although most respondents shared the view that aid was flawed prior to the cuts, they relayed disparate and at times buoyant, other times resigned accounts of possible futures. So here we have the first two quotes talking about kind of hope and possibility in rethinking, and this is from actors at global education institutions, both based in the US and outside. So for instance, I am hopeful. This gives us an opportunity to restructure, rethink, and change our ways of working. I'm hopeful there are enough people out there who are fed up with this and the way things are, and continues to talk about cautious optimism. And then another person said, what we're doing is not working. We've had 70 years of humanitarian aid, and one country has pulled funding and taken HIV and medicine away for 25 million people. So whatever that system is, it's not working. But on the other hand, folks were also saying that this is not a rosy picture, that this is not a phoenix rising from the ashes, that instead it's chaotic and it's harmful and it's damaging. And similarly in Malawi, people described the shock and damage done by these cuts in relation to the problematic aid relations they'd endured for decades. Malawian participants sought to reclaim ownership in managing local problems as foreign funders, donors have encroached on formerly sovereign policymaking spaces like education and health for a long time. So USAID, for instance, will no longer set the agenda for what matters in education. However, so here we have folks talking similarly about how today's misfortunes could lead to good fortunes tomorrow. This is actually the president. I took this from a news article. The president talked about a child sometimes grows the same day his father dies. And we can talk about the choice of language in that particular quote by the former Malawian president. But the idea of moving beyond bilateral relations to multilateral relations, the quote at the bottom, Malawi needs to rise up, does sound a bit like the phoenix metaphor that somebody else was saying is not realistic. So we see both being held together. And we had other people talk about how basically the funding gap in Malawi is just simply too large, and the suffering brought from this will be too great to kind of think in these optimistic ways. For instance, as I mentioned before, USAID funded 13% of the country's budget and 80% of the education development budget. And a lot of people talk specifically about climate change as well as kind of further rendering the government incapable of responding to particular things as need and challenges increase. So this brings me to the big new project, which is launching this summer, and which is conducted with Dr. Steve Shaw and Dr. Nelson Nkoma from two Malawian institutions and Dr. Lincoln Morley from Michigan State University in Selma. And what we're going to do is have a collaborative longitudinal study that focuses on 3 organizations in Malawi, 3 public organizations, a local NGO looking at girls' education, a health-focused public university, and a third yet to be determined organization looking at how they're navigating these changes and how they're kind of forging alternative resourcing futures. And we're also doing, Dr. Steve Shaw is going to lead an archival portion looking at Malawian political economic thought that can help kind of forge new possibilities. And I'm happy to talk much more about it, but I do want to just say that while scholars have long sought alternatives to development, little is known about what these alternatives look like in practice. There's a large literature talking about beyond development and beyond aid, and very little detail about what that might mean. So our project follows Malawian critical economist Thandika Mkandawire to imagine development as, quote, an emancipatory project. So what it might look like if imagined as such. And as austerity reconfigures education and health globally, we seek to understand how those at the heart of education and health forge new possibilities. And by doing so from the perspective of folks in Malawi versus an international organization, we're hoping to make space to think about well-being beyond Western onco-epistemological frames and think kind of more broadly and holistically about what well-being can look like and be achieved for all of us. Thank you very much. Thank you.
Okay, I wonder, do you guys both want to stay up there? Fazio, do you mind coming back up? And we have time for a few questions for either the presenter. Watch for hands. Any questions? Julia, and then there.
I will speak. Thank you, Polida and Rachel, for your presentations. Very interesting. My research is also, I'm also tracing the funding cuts for global health and tuberculosis response. And just now I'm working on the chapter which is called Rupture. So I found a lot of, similar topics. And my question is, Fazia, you mentioned this MOU, right? Memorandums of Understandings. I know they're in a very secretized space. It's not very easy to find information about them. And could you please elaborate a little bit more on what you found when you do analysis, where you find them, and what did you find most striking in your analysis when you analyze the discourse in these polls? And to Rachel also, I think maybe it's connected. So you shared with us like future imaginations and some hopes that something should happen to turn this today's misfortune into fortune. So your theoretical like background work analysis, does it give you some leading on what should happen? You know, because what I observed also that now like a lot of discourses like to charge the countries with responsibilities of not taking care of the health of their own people in a way. And for me, it's a little bit like countrification kind of thing. So countries are now in charge, but all these external influences are not being addressed. So do you see any answers to that? Like, you know, how not to make the countries the ones to blame for, let's say, not being able to address the health needs of their own populations, and what are these broader macro factors? What should happen in the macro level in order to enable them to address it? Sorry.
Question, no, really good question. Thank you so much for the MOU question. I was so hoping someone would ask, but then also
I was gonna ask too.
Yeah, so then my mind is not completely done on it. So I hope I answer it as best as I can. And I'm curious of I know Malawi has signed an MOU in January, so I'm curious of what's in that, and I haven't looked into it to engage in a very meaningful way with the details. They're complicated agreements, and most of them, what you can know about the MOUs is from press release, mostly from the State Department. And so we don't have a complete picture of what they are and what they entail. I think a lot of us in the global health community have found them very great and very cruel, very difficult to swallow. But in the cases that I have seen, I think a knee-jerk analysis or an initial thinking would be like, oh my goodness, this is going to lead to so much military engagement. These MOUs are often type of the kind of key cases that were fed back in the case of the African MOUs. And again, this is around 26 countries in the world. Countries in Latin America have signed them, countries in Africa have signed them. And along the day, Senegal signed theirs. They were, I think it was Honduras that was also signing a completely different MOU. And some of the key cases, examples that were given is, for instance, in Nigeria, some of the funding was really targeted at faith-based organizations, Christian organizations. There was sort of a clear political agreement there. In the case of Zambia, they were attached to some of the public health deals, were attached to mining contracts, the US mining contracts. These are the sort of worries that people in the global health community have had around the sort of blackmailing, really, that public health is being used for larger corporate gains and American gains, obviously. And so this is the critique that's emerging initially from scholars and practitioners who are observing the signing of those bilateral agreements. The knee-jerk analysis would be, the language is very much linking public health and military and security apparatuses locally and within sort of national and US foreign policy. There's an argument to say like the masks has fallen, I think, in a little bit from the discourse around development funding being cut. I think there is an argument to be said that, these were some of the dynamics that were always at play, and that now it's sort of a more realistic, or at least honest almost interaction. I think in the case of the MOU and the role of military actors, the obvious thinking is that the language and the discourse is increasingly worldwide linking public health and military security gains. I think what we know from global health diplomacy is that countries emulate each other, and that if the US is signing these sort of bilateral agreements, the countries might also position themselves in doing the same thing. So the fear from commentators is that we'll see the multiplication of those kind of bilateral agreements in public health, and then a lack of multilateral thinking, right? And that it also bypasses sort of regional bodies, sort of the African unions and people who have already been thinking about this work, in a concerted, integrated manner, and that this really fragments the sort of institutions that we've had to think about civil military health delivery, for instance, but also just all of the very, very pandemic preparedness and public health agendas that have been conceived in Afghanistan. So that's the first analysis. But then the second question is that when you think about the terms about military involvement, this doesn't necessarily mean that there will be more military involvement in healthcare. Quite the contrary, the military is increasingly, if you look at the way defense spending is going, it's really hard sort of lethal weaponry, very hard defense, right? And in terms of US military engagement as part of global health policy in the last 20 years, it's been very much a bipartisan issue. So both the Democrats and the Republicans have pushed, for instance, African programs of military capacity building in healthcare systems across Africa. This new agenda, so the Trump agenda, seems to be much more military, hard military. So not necessarily, so the knee-jerk analysis would be like, oh my goodness, the global health is being militarized by this type of agreement, but I think we need to step back and think a little bit about what it means in the long term, and also just that as always for me, this is a question of civilian capacity. So where, and this is what I've tried to do in the workshops with colleagues, is if the military is being involved, what is it that we're lacking in terms of civilian capacity? What is it, what is it that we need to beef up from a civilian side? It's a great way to shed light on our lack of capacity from a pandemic preparedness, public health, and health. I hope that responds to your
Thank you. I was going to ask the MOU question as well, so it's very interesting to hear and truffle. And yes, as you said, it feels like it's almost more nakedly transactional instead of sort of this veneer over the transactionality that aid has. I'm thinking about how to answer your questions best because they were big and wide ranging, and so I think I'll say a couple of things. I'm hearing you kind of identifying concern that in this shifting to like post USAID realities, there will be kind of a blaming of countries for their inability to fund particular systems and sectors without a critical analysis of kind of how we got there. And I would just point to, in part, the literature and theories that have been generated in a lot of these kind of quote aid receiving spaces for a long time that have laid out this dynamic long before this moment. And so part of what I'm excited about in our project is that I'm partnering with, I'm not an expert in Ubuntu and other ontologies and epistemologies from the region, but the colleagues that I'm working with are. And so I'm an anthropologist of policy that looks at how people are doing their day-to-day work and making sense of these power relations they navigate. And so is Alyssa. But the two people we're working with have long been writing about other ways of conceptualizing education, for instance, and other ways of thinking about aid itself. And so I think kind of letting them lead in framing the project theoretically in ways that move beyond. I mean, I think critical development studies, critical political economy are extremely important. But that kind of helps us identify the problem. It doesn't necessarily chart pathways for alternatives. And so I look forward to learning more from the folks that I have the opportunity to work with. And that's part of what the archival research will do. It's part of what, reading literature outside of the US, Canada, and Europe can help do in understanding this moment, et cetera. And I think that's a kind of limited answer to your question, but that's where I'll start.
Thank you. That's great. And thank you for summarizing my questions so nice.
Really interesting answers, questions and answers. We have time for, we've got 2 minutes left in this little segment. So yeah, we'll go to the back. So hopefully quick.
So my question is, so I'm Kadirvel, I'm a good PhD student in global health. So my question is not exactly on the methodology or the findings from both of your studies, but I'm just seeing there are 2 dots sitting here or standing here, and then I'm just seeing it as a line, because the one side I think Fazwa presented as a description that there is an increased military investment. The other side there is a US cut. I'm also just seeing there is a clear temporal relation that there is a USAID cut, and then followed by there are a lot of military actions and investments. How do you kind of connect these 2 dots, and then what are the kind of possibilities of linking these 2 dots and making meaningful research output, but also that is very important.
I mean, it's a great question. I wish we had a coffee together. Because we've just met.
Have lunch.
About it after lunch. I think I did read some of your project, before coming and when it was announced, I think on the DI website. And I do think it's very important that we do not work in silos, and that we can. I think a lot of my research I have found a bit disheartening in the last year. And it has this seed grant that's so wonderful to be able to reach out to colleagues and get out of isolation because that's researchers were often so isolated. So I have found it to be a wonderful opportunity for solidarity and like therapy and meeting like-minded colleagues. But I think a lot of my work has been looking at the darker side, and I get a lot of hope from hearing from Rachel's research, and because I think oftentimes as critical scholars we look at it's a bit what you were referring to in terms of critical theory, is that we look at sort of, you know, we critique, but then what? And I think often with my own work I have found that I'm really drawn towards, for the next phase, it's very drawn towards, you know, that next step that you're alluding to, which is collaboration with you know, healthcare providers and education providers to see, you know, what are the direct impact of military funding on programming. And I haven't really done that thinking yet. I've been very much involved in the critique. Yeah, you know, thinking of I don't know what you think.
I mean, I love what you said. I agree. I think that's the two big trends happening right now in the sector. I think part of how people are making sense of it is by saying, okay, if we're going to take the veneer of aid as benevolent away and point to what's actually going on and why. I mean, I'm not saying all aid is inherently instrumental and about militarization, but much of it from the foreign policy perspective from places like the US is. So perhaps by kind of clearing the cobwebs in such an extreme way, we could say, here's exactly what's happening. And, you know, folks in Malawi are talking very openly about, we've always known that aid is instrumental, is related to the military. Now we can talk about it, and now perhaps we can be a bit more strategic. I mean, still limited already the MOU, but at least we can kind of talk more openly about the transactionality of it all. I do think, you know, here's an example also of how it's linked, and this is not hopeful, and I'm sorry. I do think there are spaces for hope. I'm planning this research trip next week in Malawi and trying to figure out how to get us together. And the price of a tank of gas, of fuel for a Camry right now is $190 for a gallon. And there's not enough fuel and people are queuing all night long. So the idea of trying to get our research team together involves basically hiring someone to sit in the queue all night long to get the gas that's now costing us infinitely more than it has costed before. And I'm thankfully, thanks to research support and thanks to my positionality in this world, able to kind of handle it for now. But if you think about all the people that are trying to forge new possibilities in the work that they can't fuel their generators and can't move around. It's a perfect example of kind of how militarization is playing out in the day-to-day, and perhaps even more of a reason we need to think beyond this together. And I think your chart was very stunning that you said, the graphic of how funding has, militarized funding has increased, military funding has increased. And maybe we'll hit some sort of break point at some moment, and maybe the rejection of these transactions will make space for something new. And that kind of remains to be seen. I mean, that's what I look forward to seeing. I mean, I know for a fact that the case study organizations that we're working on, one of them lost 50% of their staff from the USAID cuts, but they're still going. I mean, I can talk about what they've done over the last year. I'll know much more in a couple of weeks when I come back, but they are still going. So I don't know. These are some of the areas of overlap that having a conversation together is far more useful, of course, than talking about them in isolation.
And on that note, sobering but hopeful, we'll end this segment, and thank you for your presentation.